Welcome, one and all. I'm Dr. Margaret Fitzgerald. I'll be leading the session today, and we're going to wait a few more minutes right till the top of the hour because we want to make sure everybody gets in and gets settled and all. And I know all of you on this either just graduated or you're just about ready to graduate from your nurse practitioner program. So, round of applause for you. And we want to be able to respect people being in here at the top of the hour, and looking forward to spending this time with you and get your questions answered on what's next with the NP boards. So we'll take that a few more minutes. And while we're waiting, I want to do something for those of you who are here, because there are a whole bunch of you already here, and I will repeat this right at the top of the hour. If you look at your control panel and the way it shows up for me on my version of Zoom, it's at the top of my screen. You'll look way over to the right as you look at the screen. There's a little circle with 3 dots in it. And I want you to click on that, and what you will see is the Q&A box. And the Q&A box is where I'll take questions. I'll be the only person who can see the information there. So all questions, I'm a big believer, all questions are good questions. But while we get going, if people could just, if you feel up to it, type in where are you from and what's the temperature, because many parts of the United States right now are in the deep freeze. So we'll do that for a couple of minutes until the rest of our colleagues join us. I'll start off. I'm from Boston. It is really cold there. I happen to be really fortunate is right now I'm in Phoenix and the sun is out and it is about, it's like in the high 60s. It's absolutely beautiful. So don't tell anyone back home on that one. Okay. Jacksonville, Florida, 58 degrees. Yeah, I understand it's been a little chilly in Florida. And I have a cousin in Jacksonville, Florida, and her lovely family. And she is a physical therapist who's nationally renowned for her work in workmen's compensation. And the fruit does not fall far from the tree. She's from my Fitzgerald line, which is my family's name. And we have a whole bunch of we have biomedical engineers, physical therapists, occupational therapists, RNs, NPs, all these people on that side of the family who are applied science people. Georgia, it's 49 degrees. New Mexico, 33 degrees. Virginia, 38 degrees. Colorado, 40 degrees. Yeah, I guess it's January, isn't it? San Diego. Okay, this is going to be annoying. 60 degrees. Every time I go to San Diego, I think to myself, I could live here because the weather is just so gorgeous, and it's gorgeous almost all the time. Orlando temperature is 60 degrees, Fresno 40 degrees, Middle Tennessee 33 degrees. Oh yeah, it is chilly. It is chilly in the good parts of the Michigan 2 degrees. Okay, there we go. We're down to single digits. We have to say a prayer for our colleagues in Michigan. Missouri is 36 degrees. Again, we're getting Florida, mid 50s, Charlotte, 31. It is chilly. It is chilly. So for those of you who just joined us, I'm Dr. Margaret Fitzgerald. I'll be leading the session today. And we were just doing, while we were filling in the blanks on what's going on with folks and getting them settled and allowing people to come here, since the session is to start at the top of the hour, tell us where they're from and what the temperature is, because the nation, almost the entire nation, is in a deep freeze right now. So we are at the top of the hour. Let's get going. And one more time, I'm Dr. Margaret Fitzgerald. I am the founder of Fitzgerald Health Education Associates. I want to welcome you to this session on Ask and Apply live exam strategies. Everybody who is on this program is a family or an adult Gero primary care NP student or recent graduate. and you are completing the Fitzgerald review course through a university. And so just so that you know, there aren't any PMH people, acute care people, those types of folks. They will have their own strategy sessions like this. So these sessions are designed for you to be able to take advantage of having a content expert, that would be me, and an NP certification expert. Again, that would be me. I've been teaching people how to get ready for the NP boards for well more than 35 years with great outcomes because of the work of my team. And so that you can get your questions answered and help you navigate getting certified. A little bit more about my background. I mentioned founder of Fitzgerald Health Education Associates. Also, my clinical practice has been at a federally qualified health center. And so during my 35 plus years in practice, I have seen everything that comes through the door: pregnancy, the little ones, the people in the middle, the older ones. It's a true family practice model where we see multi-generation families. I'm also on faculty at Case Western Reserve University, where I did my doctoral studies. In fact, I just finished speaking for them out in California. I'm a member of the Pharmacy and Therapeutics Committee of a major HMO in New England. I do probably a half a dozen other things: author, consultant, professional speaker, et cetera, et cetera. So why do I bother even saying that? And those of you who have been on other sessions have heard me say this before. I just want to remind you that the NP profession is amazing, what you're going to be able to do with this. All right. So what are the purpose of these sessions? To support your success, to answer your questions and concerns as you get ready for boards, and then to build confidence. Now, here's one thing: test taking abilities. Build confidence in your test taking abilities. Actually, I'll be candid with you. Next session we're together, you're going to see I edited that. That was another person's input that said, "Oh, people are worried about their test taking abilities." You're excellent test takers. How can I be so bold as to say that? Here's the reason why. Look at the degree you hold or you're going to finish holding very soon. You have an advanced degree. An advanced degree. Very few people in this country, and even very few people within nursing, have advanced degrees. You are inherently an outstanding test taker. You've demonstrated that countless times. NCLEX, RN level certification, SAT, GRE, the list goes on and on. You're an outstanding test taker. Remember that. You wouldn't be here if you weren't. You know what you do need to work on is the essence of passing the boards. And this is all about your clinical decision-making skills. So I want you, if you are feeling like, yeah, but I'm really not that great a test taker, I want you to take that, put it out of your mind and say, while I'm getting ready for boards, I am going to work on my clinical decision-making skills, because that's what's going to give me board success, okay? And remember, passing the NP certification exam shows your understanding and application of essential knowledge to entry-level NP practice with a focus on primary care for family and adult gero primary care NPs, okay? Entry level, but at the APRN level, and you were not prepared as a generalist. You were prepared as a primary care specialist, okay? Primary care is its own specialty. And I am a dyed-in-the-wool, very happy primary care provider. It's not everybody's cup of tea. I realize that. And I also appreciate that only about 40% of you will end up practicing in primary care. I appreciate that. Okay. And many of you became nurse practitioners because you're at the RN level now, you're in oncology or you're in cardiology or you're in something like that. And that's your passion. Good for you. Good for you. While you're getting ready for this exam, remember you're being tested like a primary care provider. So that's what your mindset needs to be. So what are the most common errors in the NP boards? Thinking like a smart RN instead of an entry-level NP. Thinking like an inpatient specialty or emergency department provider, not like a primary care provider. I can't say the next one strongly enough. Focusing on practice questions instead of building your knowledge so that you can demonstrate I will be a safe entry level provider of primary care. Okay, that's what the boards are all about. And last but certainly not least, expecting to immediately recognize the answer of a question when you look at it. Very, very, very few questions, if any, will be written at that basic recall. And if you're saying, what the heck do you mean by that? It's like a basic recall question is the when evaluating or which of the following is cranial nerve 1? A, olfactory, B, auditory, et cetera, et cetera. You know, that would be you either know the answer or you don't. By the way, cranial nerve 1, it's your olfactory nerve. It sits in your one nose, and the optic nerve sits in your 2 eyes. So there you go, 2 cranial nerves now. You're not going to get basic questions like that on boards that are all about memorization. They are all, every single one of them are evaluating your clinical decision-making skills, every single one, okay? So you're going to be tested as a diagnosing clinician with prescriptive authority. Therefore, as I just said, this quick recognition recall, flashcard study technique, limited help because it tends to focus on factoids. Low-level practice questions, probably more harmful than helpful. I taught an NP review course in person just like about 8 or 9 days ago, okay? And I love teaching online. I adore teaching in person, okay? I'm thrilled that we can teach online because it opens the opportunity for so many more people to be in the fold of learning together. But on the other hand, I adore teaching in person. And I had more than one person come up to me, and I had a good sized group, like 70-ish people in the room, who came up to me and said, gee, I've done the fill in the blank practice questions and I'm scoring 90% on them. And I do things from your book, Dr. Fitzgerald. I'm only getting 65% of them right. And I said, yeah, it's because the other questions are too low level. And the majority of questions out there for sale are actually too low level. Okay. Am I going to tell you which ones not to buy? No, I'm not. No, I'm not. But I believe once you compare perhaps products you've already purchased to what Fitzgerald Health offers, you already know. Okay. And so you have to take the time to analyze and synthesize all the information. And clinical reasoning takes a little bit of time. You can't look at the computer screen and go, oh, second option, that's the right one. Next. No. I'm going to give you an example now. This happens to be the AANP's example, and I'm not favoring them over ANCC. It's a little easier to go over because ANCC is 3.5 hours and 175 questions. AANP is 150 questions and 3 hours. So example, you have 150 questions, 180 minutes are allotted, 180 minutes, 3 hours. 1 question per minute, which is how much time you should spend on each question. And if you say that doesn't sound like much time, it's actually plenty of time. And then remember, you will be able to highlight questions and go back to them. So this does not resemble NCLEX in any way, shape, or form. And you'll have plenty of time to go back and highlight the questions. Review the highlighted questions and use your full testing time wisely. At least 1/3 of the people that I talk to who have failed boards say, the test was easy, I got through it in no time. And you know what they were doing? They weren't doing the analysis and synthesis of the information provided. They weren't looking at every single word in the question itself. Really key to keep in mind. So what percentage of the people who failed boards thought that test was easy and I got through it really quickly? It's about 1/3, about 1/3. It's actually one of the most common things I hear from people who have failed boards. Now, here is something I should have said earlier, but remember, for those of you who were on, we got on a few minutes early before the top of the hour, and I said, take a look at your control bar. Way over to the right, you'll see a circle with 3 dots in it. Click on that. You'll see the Q&A box. And what I want you to do is, as I do my prepared remarks, put in there questions for me. Okay, I'll probably speak about another 10, 15 minutes, and then we'll move on to the questions that you need to get answered. I want you to put them in there. What are you struggling with conceptually? And what I would ask you to do is narrow it as much as possible. Like, not, it's a little hard for me to answer the question, I don't understand anemias. But if what you say to me is, I'm confused between microcytic and macrocytic anemias, I've got a place to start. All right. So try to narrow your question down as much as you can. When studying for the NP boards, conceptualize, do not memorize. I can't say that strongly enough. Can't say that. All right. So what we're going to do now is we're going to go through a clinical scenario on case scenario clinical decision making. So we've got a 58-year-old woman. She has a 5-year history of hypertension, type 2 diabetes, and dyslipidemia. So I'm trying to make it look like I'm not fiddling with my computer screen here where I am, because I have to minimize. I've got images up there that are keeping me from seeing the whole question. So one more time, 58-year-old woman, 5-year history of type 2 diabetes, hypertension, and dyslipidemia. She presents for follow-up care. She's without complaint and states that she is taking the following medication at optimized doses as advised: metformin, atorvastatin, telmisartan with hydrochlorothiazide. So a couple of things that I want you to keep in mind here is you will often be given drugs in their generic name. On rare occasion, you'll be given a brand name. And now you're being tested as a prescribing provider. Okay, you wrote all of these prescriptions. So what you have to do now is say to yourself, okay, metformin, what is it? Technically, it's the drug class is biguanide. Nobody remembers that except somebody like me who teaches pharmacology. And it's an insulin sensitizer. Atorvastatin, technical full name is HMG-CoA reductase inhibitor. When was the last time you heard anybody call them that? No, it's a statin. And what's the strength of the entire class of the statins? LDL lowering. They are the LDL lowering powerhouse drug of the universe, okay? Telmisartan, it's got that sartan suffix, so it's an ARB, angiotensin receptor blocker, and hydrochlorothiazide, thiazide diuretic. Very common drug combination for somebody who is on, who has these 3 diagnoses. Recent labs reveal the following. A1C is 7.8%. Now, remember, you don't need to memorize lab norms. They'll give you the lab norms on the boards. And so remember, goal A1C for her would be less than 7%. And her estimated GFR is 55. And so, more, shall we say, acceptable GFR for somebody in her age group would be actually greater than 90. So she has a GFR that is down. And I'm doing this off the top of my head, which is always dangerous. I think that's stage 2 CKD. Okay. Now, what does that mean in the day-to-day? She has enough renal function in the day-to-day that there are virtually no meds where the doses would need to be adjusted, virtually none. You know, if you get into like super subspecialty practice, maybe there's a chemo that might need to have the dose adjusted, but it's not something that we're doing the day-to-day in primary care. Plus, we're not given that she has some exotic diagnosis behind all of this. But the other thing we need to remember is she's only 58. We would like to see her be a very old lady someday, wouldn't we? And a very old lady in good health with reasonable renal function. So you've got to protect all those little nephrons that are in there. Important to remember too, when you see a lower GFR like this, kidney is not the liver. The liver is wonderful at regenerating. The kidney is not. So which of the following is the most appropriate next step? So this could be looked at as an evaluation question. And evaluation as defined by the NP boards is the person's already been assessed, diagnosed, and treated, and now you're looking at response to care. So this would be an evaluation question here. So what do we know? Limited history. We're being told we're going to assume she's tolerating the meds without adverse effects. Metformin, as I mentioned, insulin sensitizer, minimum hypoglycemic effect. Why does it have low hypoglycemia risk? Because it sensitizes the body to utilize its own insulin. It does not impact insulin release. Remember, yes, there are more fancy drugs now for the treatment of type 2 diabetes, like the SGLT2Is, the GLP-1 agonists, et cetera, but this remains a first-line type 2 diabetes med unless otherwise contraindicated, okay? Atorvastatin, as I mentioned, lipid lowering. Comment on the optimal dose, probably on high-intensity statin therapy, given her comorbidity. That will lower LDL by more than 50%. So if the LDL started off at like 180, it's going to bring it down to 50% of that or less. And the telmisartan, remember, ACE inhibitors or ARBs remain priority meds in high blood pressure with type 2 diabetes, as dictated by the ADA. So in other words, she's got some renal protection on board already. And you know what? And this is the way you need to think, because you're now a prescribing provider, okay? Do you see what I mean? That you can't just buzz through this question and go, yeah. Let me get to the end. The other part, what I want you to notice is every single word in the stem of this question was important. Every word. So as I mentioned, her goal A1C should be less than 7%, her GFR 55. So she does have stage 2 CKD. And if you're going, ooh, metformin, CKD, we need to discontinue it. No. When do we discontinue metformin? We discontinue metformin when the GFR is less than 30 due to the lactic acidosis risk. Is metformin nephrotoxic? It's renally eliminated. And you know, there are a number of different nursing pages that I follow on social media. And one of them that deeply disturbed me was, and I don't want to be disrespectful of the RN role. Quite frankly, I don't know how these people do the RN role anymore. But one RN commented that almost every person she sees who ends up on dialysis was on metformin at one time or another. And implying, and a whole bunch of people chimed in and said, yeah, I'd never take metformin. It's too hard on the kidneys. No. It's not hard on the kidneys. It's not hard on the kidneys. It is renally eliminated. And that's why we get rid of it once the GFR is less than 30. But metformin's cardiovascular benefit is well demonstrated. And it's the disease of type 2 diabetes and hypertension and dyslipidemia that cause the CKD, not the metformin. All right. So breaking down info not provided, because I know that what you want to do is you go, yeah, but. I want her vital signs. I want her BMI. I want her lipid profile. I want more of her chem profile than just what her estimated GFR is. Too bad. Get over it. Move on. All right. Anytime you go, yeah, but, that's going to get in the way of your clinical decision making. This is not uncommon on boards. You will get just enough to answer a question, but very little more. And the boards are an exercise to see if you'll be safe to practice. They're not a full treatise, if you will. Okay. So, key principle in type 2 diabetes care: choose medications while considering comorbidity, including CKD. She has stage 2 CKD. By the way, just a reminder, there are 5 stages of CKD. Stage 5 is with GFR of less than 15. It is either renal replacement therapy, aka dialysis, or compassionate end-of-life care, right? And so I just want to give you a reflection of how far she is from end-stage renal disease. So you want to take a look at CKD, focus on treatment goals, maintain glycemic and hypertension. Goals are inherently renal protective, okay? So which of the following is the most appropriate next step? A, discontinue the metformin. B, add an SGLT2I, a gliflozin drug. C, add a DPP4 inhibitor. D, initiate sliding scale insulin. All right. So the best answer here, of course, is add an SGLT2I. So let's take another look at this. Why not discontinue the metformin? Well, if we think metformin brings A1C down on average about 1 to 2%, and her A1C was 7.8. It's too high. We don't want to just let that slide. She probably started off about 8.8 to maybe 9.8 for her A1C. So the metformin's done a decent job of bringing it down. One more time, $4 a month. It is a little miracle of a drug. Add the SGLT2I. Yes, she has established CKD and her A1C is above goal. It's going to address both clinical issues, the CKD and the A1C. Now, here is something I want you to remind you the following. My practice has been in the lowest income urban neighborhood in a 6-state region for more than a third of a century. I know it can be hard to get more expensive meds like SGLT2Is, particularly for people with limited resources. But one of the backbone components of the boards is you can access these meds. Or just to throw it out there, it's a 52-year-old who's had no primary care for 10 years. Order the darn colonoscopy. Assume you can. All right. So we can't, yeah, but, and say, yeah, but it doesn't say her insurance. Yeah, but it doesn't say whether she's got money. No, we know in real life that happens. This is the best answer. Option C, add a DPP4 inhibitor. This is one of the gliptin drugs like sitagliptin, Januvia, Onglyza. There are a few others. That is an insulin releaser. It's a good insulin releaser because it's smart glycemic control, but it's not going to address the CKD. So it is not a bad answer, but B is a better answer. And then D, friends don't let friends prescribe sliding scale insulin. Full stop. Full stop. And you say, yeah, but in the acute care setting, we use sliding scale all the time. Actually, what you're using is correction insulin because the person is sick. And when you think about it, first of all, in the outpatient setting, sliding scale, we just don't do it because it is a reactive way of treating hyperglycemia. And what you're saying is, I am going to let your blood sugar go up to like 275 after you've eaten lunch. And maybe you had a few more carbs than you were planning on. Okay. I'm going to let it go up to 275. Then I'm going to teach you how to chase it down. And what's happening then, you've allowed, if you will, all that damage to the body, inflammatory damage, messing up her kidneys even more, to happen with that hyperglycemia. And then you're trying to chase it down. And you know what sometimes happens? The next thing you know, the person's blood sugar is 50 and they're symptomatically hypoglycemic. So if you ever see initiate sliding scale insulin as an answer on NP boards, I could almost write you a guarantee it's incorrect, even though you have seen that done. So remember, NP knowledge equals NP power equals NP board success. So what I want to do now is turn this over to you folks. Here's something else I just want to throw in there. If any of you are going like, what the heck, I was lost on that case study, please call me on it. Call me on it, okay? So on the actual test, do you get follow-up questions? I'm assuming what you mean is meshed questions. So question number 1 in the bundle might be this woman, and I'm going to call her Maria just so that we have a name for her. Maria, blah, 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 blah. And then the next question is, Maria is also behind on health maintenance, and there's more questions. You tend not to do that. I know in the review course, we have some questions like that. And part of that is the review course is, it's a learning exercise. Okay. That's what the whole thing is. So that's why you'll see things like that. So follow-up questions or meshed questions where there's one case study like Maria, then 3 questions, you're unlikely to get that. You might get 2 questions in a row that are meshed, but the longer meshes you tend not to. Now, follow-up questions, do we get follow-up like this? Like the patients coming in for follow-up? Absolutely, lots of those questions. Remember, probably about 20% of the questions on the boards will be response to care. I'm reviewing antibiotics. Do we need to know brand, generic, and drug class? It seems overwhelming. Brand, they might throw it in to throw you a bone. They might. I wouldn't even give that a second thought. Generic, yes. Drug class, yes. Now, I hear you when you say it seems overwhelming. And by the way, next week's session, I'm actually going to give you a whole bunch of hints on recognizing drugs by their class. So give me a little bit more direction on what you mean by it seems overwhelming. Now, you also have to realize I don't find it that overwhelming, but I have been doing this for decades. And I also teach pharmacology, and I know drug classes by their prefix and suffix. Will ANCC give lab norms as well? Yes, but it would be what you're more on AANP, you're more likely to get the lab norm, or I shouldn't say even the lab norm, the lab value. Like this one, her A1C was 7.8 and her GFR was 55. Boom, boom, numbers. ANCC tends to do more that they would say something like, she has stage 2 CKD and A1C not at goal. In other words, more of a verbal description of what's there rather than the actual numbers. And you might go like, well, that doesn't seem right. You know what? Your answer would be absolutely identical. Absolutely identical. So keep that in mind. All right. Thank you for this question, because you know what? I don't think I've mentioned this in the session so far. And this person has hit it spot on. With the 2025 guidelines for hypertension care, ethnicity was taken out as an example of recommendations for African-American patients. Well, first of all, yes, hallelujah, hallelujah. And I've practiced for 3.5+ decades in a community where I am not a member of that community. Okay. I mean, I'm an older white woman of European ancestry. Most of my patients are African Caribbean ancestry. from the Dominican Republic, Puerto Rico, some of the more northern parts of South America. Anyway, I think I've made my point. And truthfully, and I mean the 120 plus providers at the clinic where I've been, have largely practiced for decades race agnostic in treating people with high blood pressure, because we knew that the guidelines that say if the person is, and this is their terminology, the old guidelines, black, you start with a calcium channel blocker or a thiazide diuretic. Non-black, everybody else, you could do ACE inhibitor or ARB or a thiazide diuretic or a calcium channel blocker. Okay. And what that did was it misled healthcare providers to think that the ACE inhibitors and the ARBs did not work in people of African ancestry. And that likely accounts for the fact that we see people of African ancestry overrepresented on the dialysis unit. I mean, the list goes on and on. So the guidelines from 2025 that took race out, and the terminology those guidelines say is the 2025 guidelines are race agnostic. They did not look at an individual's race. Okay. Those guidelines came out, if I'm not mistaken, the second or third week of September. The exam you're going to sit for, coming up now, was likely written early to mid 2025. So those guidelines would not have been there. However, here's the deal. What they might have done is gone in and tweaked a few questions on it. And I'm going to give you an example from our review course. There is, in the hypertension section, there is a man, I think last name is Jones. I think he's in his 50s. He is a Black man on a solo drug for the treatment of his high blood pressure. And his BP, I can't remember exactly. It's like 160 over 90. It's not alarming. But his blood pressure is still too high. So that's an evaluation question. And if you recall from that, the answer is to add, I think he's on a calcium channel blocker. The correct answer for that was to add a thiazide diuretic and see him back in 2 months. Okay. So it was one of those questions that had two answers. No, I'm sorry. Rewind the tape. Add a thiazide diuretic and see him back in 1 month. And that is the correct answer. Guess what? It's the correct answer even with the newer guidelines. Because if you look at the other options, so one more time, the correct answer, thiazide diuretic, see him back in 1 month. So there's another option of starting a different med, but see him back in 2 months, I think it is. The key to the fact that that answer remains correct is because a thiazide diuretic would be a really helpful drug for him. Seeing him back in 1 month is the recognized time interval for reevaluating somebody who has recently had a high blood pressure medication dose adjusted or a new med added. And then one of the other answers for that guy is like, leave him be because he feels good. While we fry his kidneys, brain, and his coronary arteries with his BP of 160 over 90. So I don't believe that the questions on the boards will be so focused towards race in which antihypertensive med you're going to start. There is something newer in those guidelines, which is the use of the PREVENT scale or score, whatever it's called. That's not going to be on your boards because it actually, even in real life, has very, very limited use right now. I think its use will grow over the next few years. But long and short, there isn't so much different between the old guidelines and the new guidelines, other than the very important part as we're looking at this with race agnostic. And so I'll make one more comment. Like if Mr. Jones was my patient in the question from the review course, he's on a calcium channel blocker. I would start the thiazide diuretic. I'd see him back in a month. And if he is 160 over 90 on a calcium channel blocker, he probably started off maybe about 175 over 98. So we're getting there, but we're still not there yet. Putting him on the thiazide diuretic will probably bring him down to about 160 over maybe about 85. He still ain't there, is he? No, he's still not at blood pressure goal. So you bet your bottom dollar he would have an ACE inhibitor or an ARB on board. And I'd max out the dose because I know maxed out ACE inhibitors and ARBs, those drugs provide more renal protection than a smaller dose. And I'm one of the things I can honestly say I'm the proudest of is 3.5 decades of primary care practice in an African Caribbean population. I have literally never had a patient go on dialysis ever in 35 years. I've got a couple of elderly patients, like one woman comes to mind, she's almost 90. She does not have a lot of extra nephrons rolling around anymore, but she's also had hypertension, dyslipidemia, and type 2 diabetes for more than 35 years. And she's done remarkably well. And she also is adamant and she's comfortable. She's highly functional. She bosses me around all the time. I adore her. I adore her. And she is like, nope, dialysis, it ain't going to happen. So we've worked very hard at preserving the little bit of renal function he had. You know, her GFR is like in the mid-20s. It's not great. It's not great. But did I mention she's 90 and she doesn't want to go on dialysis? So we're just trying to keep her healthy and as healthy as she can be. Okay, so I find the diabetes meds and their function overwhelming, as well as I have mostly pediatric experience. Yeah, so one of the things is you're starting kind of from scratch. So please give me, and I say that with great respect for your PD experience, but you're newer to all of this. Tell me what's confusing you about those meds, okay? I'm taking my boards this Friday. I'm having a hard time remembering all the antibiotic generics coupled with their drug class. Okay. Now, first of all, I want you to remove the word remembering and say, I'm challenged by conceptualizing the hypertension meds. I'm sorry, the antibiotics. I'm not going to go through all the antibiotics, but quick and dirty, because I want to make sure you get this, because you can't wait for 2 more weeks, can you, for me to go over the generics? All right. Antibiotics that are used in primary care, that's going to be your focus, include the beta-lactams. They all have a beta-lactam ring, okay, which it describes their molecular function, okay? This include the penicillins, which includes amoxicillin, ampicillin, and plain old penicillin, right? So how do you know those? Cillin suffix on them. Now, what's a commonality for all of those? What do we know about amoxicillin, ampicillin, penicillin? By the way, amoxicillin biotransformed by the body to ampicillin. Why do we use mox more than ampy? It's fewer doses per day, and it's a little easier on the stomach. Okay, that's the only reason why. Plus, liquid amoxicillin tastes like bubble gum or strawberries. It's delicious. The kids actually usually like it. Okay, so what do we know? Most of the time, we use these cillins to treat bacterial respiratory tract infection. And what causes most bacterial respiratory tract infection, like acute bacterial rhinosinusitis, acute otitis media? Those are going to be the big 3 bugs: Streptococcus pneumoniae, and if you give enough of one of those penicillins, it will eradicate it. And then Haemophilus influenzae and Moraxella catarrhalis. I'm going to kind of forget about Moraxella catarrhalis because when it causes ABRS and acute otitis media, it almost always goes away without an antibiotic. But one of the things is about 30% of the Haemophilus influenzae will produce an enzyme that called beta-lactamase that busts open the beta-lactam ring and the penicillin, ampicillin, amoxicillin molecule and destroys it. Okay, so that's one of the vulnerabilities. But also with ABRS and acute otitis media, H. flu bacterial infection often goes away on its own, right? So those are the psyllins. A couple of other things to keep in mind: easy on the kidney and no drug interactions, right? So the cephalosporins, only one has a CEPH prefix for the orals that we use, and that's cephalexin, and was actually the first oral cephalosporin to come to the market, and that's the drug Keflex, generic Keflex. The others have a CEF prefix: cefpodoxime, cefuroxime, ceftriaxone. I think you're all familiar with that. These are also beta-lactams because they have a beta-lactam ring, but what they have is a protective side molecule that protects the beta-lactam ring from being destroyed by beta-lactamase, okay? So they'll be stable in the presence of beta-lactamase for bacterial respiratory infection. They cover strep pneumo, they'll cover the H. flu and the MCAT and be stable in the presence of beta-lactamase, right? So can you see just me rattling off what these drugs, what their names are, it's going to be of no help to you. What you have to do then is take it the next step and say, so what conditions am I trying to eradicate these bugs in? Okay. Cephalosporins and penicillins, safe to use in pregnancy to boot. Okay. And the cephalosporins play a smaller role in the treatment of UTI. Okay. And the cephalosporins, again, no drug interactions, great with wonky renal function and everything. Okay. The macrolides, azithromycin, clarithromycin, erythromycin, they all have that mycin suffix. Okay. Erythromycin is not going to show up on your boards. So I'm going to push it to one side. Murderous on the stomach. Oh my God, is that tough on the stomach? Okay. Azithromycin, we all know that. Zithromax, the Z-Pak, the people coming asking for a Z-Pak. Okay, so I'm going to stick with bacterial respiratory tract infections here, like AOM and ABRS. The macrolides are no longer recommended for those because their strep pneumo coverage stinks because it's been worn out from overuse. But they are effective against H. flu and MCAT. The macrolide, particularly azithromycin, plays a minor role these days in the treatment of select STIs. I'm going to leave that at that. And one of the benefits of the macrolides, they cover the atypical pathogens like M. pneumoniae and C. pneumoniae, which is one reason they play, again, a minor role in treating pneumonia. Okay. Last class I'm going to talk about because I've got a bunch of other questions to answer. The fluoroquinolones, floxacin suffix, ciprofloxacin, levofloxacin, moxifloxacin. All right, what do those do? First of all, I'm going to talk about levo and moxi because those are respiratory fluoroquinolones. Fairly strong strep pneumo coverage, H. flu, MCAT coverage, stable in the presence of beta-lactamase because no beta-lactam ring, none, zero beta-lactam ring, but not recommended first line for anything when you've got a choice of another antibiotic because of adverse effects and development of resistance and things like that. I'm going to kick it back to you and tell you, go through your workbook, go through your course, look up doxycycline when you would use that. Also, look up when you would and would not use trimethylsulfamethoxazole or Bactrim. Okay, it's all in your workbook. Will they ask dose questions? No. They're going to ask questions on your walking around information. What you have up here or any other entry level provider in primary care would have up here in your brain on the hard drive without needing to look it up. Your lookup answers would be drug doses. They might say something to the effect of, you've got a patient with diminished GFR. They're on an ACE inhibitor or an ARB. What are you going to look for more when they're on one of those meds and it's hyperkalemia? Can you hold one moment, Mark? Do you hear that buzzing sound? Oh, yes. Go. Can you check? There is some kind of a beeper going off. I'm sorry. I just had to. My husband is here with me, and I'm hearing some kind of a buzzer, and we're not at home, so that's the thing I'm looking for. It's in that room. It's coming from that room. Okay. I know you said not to memorize, but for cranial nerves, okay. You know what? If you like mnemonics, be my guest. I'm not encouraging their use, but for cranial nerves, mnemonics can work. Okay. So your question on anemias is MCH, MCHC, and RDW. I got to kick it back to you. Narrow it down a little bit more. What's confusing you about those? For hypothyroidism, are we mainly looking at TSH for testing? Yes, because it is the most helpful of the myriad of thyroid tests that are out there. And the main reason is the following. Most of the time in primary care, what you're going to do is have somebody who says to you, I'm tired, my skin's dry, and I'm going to make it a 45-year-old woman. Okay. I feel exhausted all the time. My skin's dry. Well, welcome to New England in January. Everybody looks like a lizard. All of us have terrible dry skin because it's cold and the air is dry. And many of us are tired too because it's wintertime. So I'm not saying we just brush people off when they come in and say, well, so how everybody feels. No. But let's say that you feel as if you're listening to this history and you really feel like you need to at least check for anemia and thyroid. Most of the time, the TSH is going to be normal. And if the TSH is normal, you're done. You don't need to do any more thyroid testing. Okay. And so the TSH is the most powerful test. Now, remember folks, I'm not looking in the chat box at all. If you've got a question for me, you've put it in the chat box, please cut and paste it and bring it over to Q&A or retype it. Okay. So, all right. Could you give examples when these are high, low, or normal? The MCH, the MCHC, and the RDW and anemia. I'm not going to focus just on those because those alone are not helpful. The first thing you have to look at is the MCV, mean corpuscle volume. And if you're wondering what the heck is a corpuscle, the more contemporary way of defining this is mean cell volume. Corpuscle is an old word for a red blood cell. Okay, or a blood cell, I should say, because many years ago they'd be called red corpuscles, what we call red blood cells, white corpuscles, what we call white blood cells. Okay, so MCV is mean corpuscle or mean cell volume, the size of the red blood cell, okay? And when there is an anemia, there are generally one of three types of anemia. Normocytic, normal size cell, where the MCH, the MCHC, and the RDW are normal. Again, this is all in your review course. And that tells me the cell has enough iron, enough globin in it, enough iron, enough protein, okay, so that it is normal size, normal color. And when the RDW is normal, it tells me new cells, old cells within a normative range. Okay. So you see, I can't just tell you MCH and MCHC and RDW. I have to go through the whole thing. Have to go through the whole thing. And MCV, out of those, the two most important are MCV and RDW. Okay, they are. So examples of normochromic, normocytic anemias with normal limit RDW are acute blood loss. Wash that out of your brain for a primary care exam. You've seen it in the RN world. You ain't going to see it there. And anemia of chronic disease. So what causes anemia of chronic disease? Chronic inflammatory conditions, chronic infection, poorly controlled RA or lupus, something like that. Okay. The most common anemia in the world will present as, if this is a normal red blood cell size, a small microcytic, low MCV, pale, hypochromic cell, low MCH, low MCHC, because there's not enough hemoglobin in the cell, elevated RDW telling me new cells, even smaller and paler than old cells. And the most common anemia in the world is iron deficiency anemia, where the red blood cell does not have enough hemoglobin, heme, iron, globin, protein. Okay, so that's what we have to keep in mind. So what's the most common reason for iron deficiency anemia? Chronic low volume blood loss. And what I'm going to do so that I can get through all the questions that have come in, I'm going to kick you back to the review course information here on evaluating the macrocytic anemias. But I hope you see how you can't just focus in on a wee part of the RBC indices. You're a diagnostician now, okay? I think I may need some mnemonics for remembering the suffixes to be able to realize which class they're in, particularly DPP4 inhibitor. Listen, if you're thinking you need a mnemonic, just correlate the two. DPP4 inhibitor, gliptin, SGLT2I, gliflozin, okay? So you don't need a mnemonic. You don't need a mnemonic. You need to be able to recognize the meds and their class. Oh, this is nice. Tina said, you're absolutely amazing. I enjoyed your course so much and I'm grateful for you and your program. And if you were by chance the person who is taking your boards this week, please report back to us and I'll spread the good word to everybody. Can you please review hepatitis panels? Okay. Be more specific on that because the hepatitis panels go on and on and on. And the person that said about their workbook, what I would ask you to do, put that message into Stephanie, who is our support person. Stephanie will be able to contact the office and get that taken away. Okay. And Stephanie, I got a couple of comments here that people haven't received their workbook. So the second person, two of you asked that, please put that into to the chat box and Stephanie will take care of that. I am not on that side. You know, I'm on the content side of things. I'm sorry that happened, but we'll make sure we get you to the right person. I'm getting another question. The person who just gave me their address, that has to go to Stephanie, okay? And follow up on TSH. I had a review question about a patient on Synthroid, 100 micrograms, which by the way, is kind of a middle of the road dose. TSH within normal limits, T3 within normal limits, ignore that. T4 slightly abnormal. What is it? Too high, too low? Okay. And the answer is, would you keep the same, increase, decrease, or remove? I knew to eliminate the decrease in the remove option, but would we need to increase the meds to get the T4 within normal limits? Here's the thing. I think the point, first of all, it's a rotten question. Second of all, what I think the point of that was, it probably had in there that the person only recently started taking levothyroxine synthroid, and they had their TSH checked at the wrong interval. There's something fishy about that question, or they recently cut it back. I can't answer that question because it's so poorly worded and it is so nonsensical that I just can't answer it. Are there many questions about safety with children? Oh, yes. About 20% of your questions will be, if your family, will be peds, and safety, 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 safety. Absolutely. Now, don't twist yourself up like a pretzel on those. Bring, for all the questions, every question's on boards, bring your common sense. Bring it. And if there is a question about something along these lines, like you're talking to the family of a baby who is developmentally on target and just started crawling, okay? What might be one of your major focuses on safety? What I want you to do is then close your eyes for a second and envision you were in your own home, in your living room, your bedroom, wherever, and say, okay, I'm now putting a baby on the floor, and this baby's going to go all over the floor. What might be a priority? How about electrical outlets? It's like they've been custom built for a crawler, haven't they? They're right there for that baby to grab onto. Okay. So it might be something like you go, oh my God, I didn't memorize all the safety things that we look at with babies. Okay. But sometimes use your common sense. Bath water temperature, always, 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 until they're old enough to safely bathe on their own, which they're old by the time they're able to do that, right? Never leave them on an elevated surface, because trust me, newborns can go like this, and you would be amazed how often newborns take spills onto the floor, because the well-meaning provider, well-meaning caregivers say, oh, but the baby can't roll. Yeah, but they've got these little bums that move. So some of this is super, super, super common sense. Burns, what's the most common way for a child to get burned in the home? It is bath water, one of the most common. Or the other thing, and I've got a cup here, like this happens to just have water in it, but what if I left this cup out at the edge of a table, and let's say it was filled with scalding hot tea, and there's a toddler? What's that toddler going to do? Oh, this handle is beautiful. Pull it down over them. So if your question is, am I going to be asked exactly what car seat they're going to go in, and when they transfer to lap and shoulder belt? No. That's more lookup information. And part of it is it's so variable. One thing with car seats with kids, the younger kids, rear facing for as long as they appropriately fit in a rear facing car seat. Okay. We're not going to try to put a 60-pound 5-year-old in a rear facing car seat. But sometimes you've got these chunky toddlers who are kind of tall and sturdily built, and they look like, they are outgrowing their rear facing car seat. But we encourage the use of a rear facing car seat until the child truly outgrows that particular model. Oh, you're also taking the boards next week. Well, we'll be thinking of you. Okay. Will they ask dose question? No, I said that before. Okay. So one last question here. A 3-year-old with a tantrum, they're screaming and crying. Do you ignore them, give them what they want, spank them, or put them in timeout for 30 minutes? I thought ignore them. You ignore them. Well, first of all, give them what they want. A 3-year-old having a meltdown actually doesn't know what they want. Okay. And they're probably way overstimulated. They are the proverbial example of hangry. I'm even thinking back to one of my kids who I could always tell she just always had a rather petite appetite, but she would eat frequently. It's just the way she was, perfectly healthy. She was also little. She just wasn't, she's 5'1" as an adult. She was always small. Okay. And when she was 3, she could talk like she was going to go to college the next day, but she just was not great at verbalizing when she was hungry, and she would start to melt down. So I had to be on the alert to help avoid this. And so, and if I'll just use her as an example. If I had said to her, come on, sit down, you need something to eat, she would have said no. And I know exactly that she was hungry. Spank them, no corporal punishment. Put them in timeout for 3 minutes. When they're not so dysregulated, maybe 3 minutes of timeout, because it's a minute for each year of life. So the 30 minutes right there is telling you no. So, and you're right, 30 minutes too long. So the one thing you do with a child having a true meltdown like this, I prefer calling it a meltdown to a tantrum, is the best thing is ignore them, but ensure they're safe. You can't have them getting into trouble because of the being in meltdown. All right. Well, that hour went by quickly. So I want to thank you so very much for your time and attention today. We will see you back in a couple of weeks. Thank you for your consideration. Oh, we had a wonderful size group today. And not last week, 2 weeks ago, we had a much smaller group, but it was also semester break and all of you were in an academic program. So again, I wish you well, and we'll see you back in the first Tuesday in February for our next session. Thanks so much. Take care.
Barton is in.
It's a great session, Dr. Fitzgerald. Can you hear me?
No,
that was a great session.
Thank you. Okay, we need to go off now because
okay.
For whatever reason, I can't seem to end the session. Thanks for your help, Stephanie. We kept you busy today. Take care.
Yes, we did. That's fine. But thank you. Enjoy.
Thanks. Bye-bye.
Bye-bye.